Please rise. Please be seated.
Good morning, Mr. Rice. Welcome. Also, welcome to family and friends to this ceremony, academic ceremony in which Samuel Rice will defend the academic thesis entitled Optimizing Image-Guided Local Treatment Strategies for Enhanced Tumor Control, Precise Local Theranostics, Drug Delivery, and Local Percutaneous Ablation Strategies. I hereby open this ceremony, and I would like you, Mr. Rice, to present your major results of your studies to the audience in a 15-minute presentation.
Perfect, thank you. Thank you for the opportunity for me to discuss my my findings. So we start off with looking at your how we treat cancer. When you think of cancer treatment, you think of these chemotherapies. So these are small drugs, small molecule drugs, just built of a few building blocks that are atoms. And what do you think about when you think about a person on chemotherapy? Usually they're ill, they're nauseous, they're vomiting, they lose their hair. And the question is why? And that's because these drugs are targeting rapidly growing cells. They're given systemically, and they target all cells that grow rapidly. So the gut lining and the hair are cells that will do that. Right? So as we've learned more about cancer and the genetic and molecular changes that occur in tumor cells, the idea of the magic bullet drug that goes specifically for tumor cells has been pushed, and we've gotten closer to it in recent years. So these new drugs are more tumor specific. These are, again, either small molecules similar in size to our conventional chemotherapies, or they can be large, made up of thousands or millions of these building blocks, these atomic building blocks, as big proteins, okay? And because of the size, that's one of the things that limits how it's distributed in the body systemically, right? So the idea of Theranostics is they want to use these drugs and leverage their tumor specificity as a diagnostic tool or for therapeutics. So creating a theranostic probe, you take one of these biomolecules, again, either a small or large molecule. They're usually connected to a radionuclide by a chelator. So these are things like DOTA or DO, and basically that's just like a linker that keeps this radioactive material connected to that biomolecule, right? And so these can be either low energy for imaging, and you have things like indium-111 for SPECT imaging, or they could be, again, low energy, but for PET, something like zirconium-89. And these are matched to the time it takes for the distribution, right? So small molecules can take on the order of minutes to hours. Large molecules can go all the way up to hours and days. And then because it's both therapeutic and diagnostic, you can substitute and put in a therapeutic particle, which are going to be alpha or beta emitters. So your current clinical theranostics, again, so you have an injection intravenously. The patient just lets the drug normally distribute throughout the body, and then you have basically arterial blood, which goes into the tumor, and it slowly, that's how it gets its oxygen, and then as it finds these receptors within the tumor that it's home to, they enter and they click onto the receptors that they're supposed to, and then slowly those will kill the tumor or image the tumor. So when you're looking at the therapeutics, you have alpha particles, right? So these are like a cannon. They go short distances, but they do heavy damage to any cells and that it interacts with by making double-stranded DNA breaks. And then you have beta particles. These are smaller particles, so you would think of these as like a pistol. So this, you need multiple hits to achieve the same effect of an alpha emitter. All right, so you click onto the receptors, you get multiple targets, and you get either one of two options, right? So you either get an incomplete treatment where there's some residual cells because there's been residual DNA that hasn't been damaged, or you can get complete treatment. And that's ideally what we're looking for when we treat cancer. You leave one cell alone, it can continue to grow and affect the patient. So systemic theranostics has been clinically performed, and these are typically with small molecules. When you're looking at larger molecules like a protein, like an antibody, it really hasn't been translated well. But with the small molecules, we see that in multiple trials, it works well, but it only partially treats the tumors. So there's still residual cells, and it's more of a palliative treatment, not something that's going to be curative for the patient. People have thought, okay, if we give it intravenously, perhaps there's an opportunity to make it more specific. And intra-arterial therapies have been attempted. So in the Netherlands, they've done a prospective trial called the Ludia trial. And in this, they used a small molecule where they injected intra-arterially into the liver in patients who had multiple tumors in the liver. And what they saw was there was an effect, a small increase, about 17% on the side that they treated versus the side that was not treated. But what ends up happening is a large amount of that drug will go into the systemic vascularity and will circulate just like when you give it intravenously. So my goal for this study was I want to improve the current clinical practices, and I want to develop new and better methods for local treatment with theranostic agents. So I studied pseudovascular isolation. So as interventional radiologists, we have this amazing ability to go into the vessels, either the arteries or the veins, and find the exact feeders to tumors. Right? So here we have just a kidney angiogram, right? So we're able to see the vessels that supply the tumor, that supply the kidney, and from there we can also see those that supply a kidney tumor, perhaps. So the idea of pseudovascular isolation is you have this catheter, again, directly within the artery, and then initially we're trying to limit the blood flow that returns to the systemic flow. So we do something called embolization. So this is where we shoot small particles. They get lodged in these small vessels that traverse and go back to the systemic system. And the idea of pseudovascular isolation is that after we do that embolization, when we actually give that local drug, we see a much larger percentage of it actually going into the tumor, and a much smaller percentage going into the systemic vascularity. So to test this hypothesis, we used a special genetically altered pig. It's called an oncopig. And with this animal model, you're able to create tumors wherever you'd like in any organ. So we created liver and kidney tumors. And the nice thing about the pig is it's similar in size, similar genetics, similar dose distribution to humans. So it's a nice model that we can compare to what would happen inside a human. So we initially looked at large molecules, right? So this is protein size. So albumin's a protein in the body. This is we used an albumin derivative, and then we tested the distribution when we gave the drug systemically, your normal clinical practice, and then also after our experimental pseudovascular isolation. So to get the dosimetry, to get the biodistribution, we got samples of different organs to see how much of the actual drug was in the organ or in the tumor, and compared our two groups. And we can see here that when you look at the intravenous group, which is the light gray, compared to our experimental model, we have a multifold increase. Over 80% of what we injected into the tumor went directly into the tumor, compared to when we did intravenous, where we got less than 20%. So we repeated this, but for a small molecule, again, just something with a number of atoms, something called, it's basically a sugar that's used in PET imaging. And again, we have a similar outcome here. About 45% of what we injected went to the tumor within the kidney. And again, equally, we had a less amount of systemic distribution. So the kidney is an end organ, and we, many of our organs are end organs, but we also have the liver, which is a common site of metastases, so we wanted to see if it worked there as well. And with our large molecule, again, we saw over 80% was able to go into the tumor and remain in the tumor, compared to about 20% when we gave it systemically. And we saw that for both small and large molecule-sized drugs in the liver. So overall, we saw that our experimental pseudovascular isolation would be able to concentrate both a small molecule-sized drug and a large molecule-sized drug within a tumor. So then we also wanted to look more at this embolization procedure. So we have ablation, which is a method to treat a tumor similar to surgical resection, where we burn the tumor with really high temperatures. And this is done with active distribution of heat from a needle, and then also passive distribution of heat. But we see that from our clinical data, that when we're treating tumors that get to a certain size, usually over 3 centimeters, we're not able to deliver enough heat to completely treat the tumor so that it can be like a surgery. And so we wanted to see if embolization can be something that would be able to assist us in this. And so here again, we embolized, these are our tumors, and we use different sizes, right? So small size, similar to our first portion, where we go into the capillaries and sort of like those interspersed vessels inside the tumor, and also larger size embolization particles. And so these are kind of going to be at the periphery of the tumor, or more central. And so from here, we see that when you go to the periphery, we are able to increase the size of the ablation zone, but it's not as large of an increase as compared to when we do a more complete ablation. And we also see things like hemorrhage, residual hemorrhage, versus when we treat with our very small distal particles, where we see a larger zone in the kidney, we see no additional hemorrhage. And then we also treated for the liver, where again we saw similar changes, where we're able to do a multifold increase in the size of the liver of the ablation compared to when we just do ablation alone. So for this portion, we saw that a smaller particle size that provides deeper embolization of all the tumor vascularity is going to produce a much larger ablation zone, and thusly a better, more complete treatment. So future directions for this project, and where I envision this going, is that I think that pseudovascular isolation will leveraging it will give us the opportunity to translate larger molecules. So things like antibodies can be used in theranostics going forward, which are really not clinically available right now. There are things that we can do, other methods that we can use to get our embolization. We can use things like temporary particles, so instead of, so that the vessels open up and we get our initial hypoxia, which will help the radiation work, but then the vessels will open and allow the tumor to be treated better. And then I believe we're going to need to do clinical trials in humans to move this forward. And then for the second part, again, now I think that we need to start treating larger tumors in clinical trials, greater than 3 centimeters in size in the liver and the kidney to assess the viability of us, again, replacing surgery as an option for local therapy.
Thank you, Mr. Rice, for this very clear and nicely illustrated summary of your results. Your supervisors, Professor Beetstan and Dr. Gomez, have selected a number of experts to, first of all, to assess the quality of your thesis. That was positive, very positive, I must say, and that's why you're now here. Questions remain, of course, and we would like to see whether you can, in this opposition and defense, we would like to see whether you can answer the questions of the opponents in an academic fashion. So that is why the opposition will now be opened by Professor Motagi. He is Professor of Nuclear Medicine. He is present online, and he's Professor of Nuclear Medicine, as I said, at the Maastricht University Medical Center and the University Clinic in Aachen. Professor Motagi, the floor is yours.
Thank you, Mr. Prorector. First of all, I would like to congratulate the candidate and also his team, of course, that is behind him on this many years of dedication and perseverance and hard work you performed to really reach this milestone today to defend your thesis. And of course, also Professor Beetstan and Dr. Muniz-Gomez, I would like to include them in this for the guidance, commitment, and obviously also their support through this journey. But there still remain, obviously, some questions and some points. You gave a very nice layman's talk now in the beginning, and I would like to go a little bit more into this concept that you at least brought up, Theranostic. So far, looking into what you have presented in your nice work, there's not too much Theranostics in it. So you're using different molecules. But I would like to ask you what would be, next to what you presented today, would be the most supporting or the most promising approach to use a Theranostic application. So maybe briefly start with what you mean by Theranostic, and then also go into a little bit into this topic.
Okay. So this is more of a proof of concept for future theranostic studies. Because the animal model is so new, I was really unsure if we were going to be able to translate, a human molecule into an animal and have it be, give us successful data. So I used surrogates of theranostic agents, and again, we ended up with positive data. But right now, with theranostics, yes, we see the field is mainly in systemic the treatment of systemic disease. So patients who have failed multiple lines of chemotherapy, who have limited options available. This is sort of now something that's being considered, and the nice thing is it is getting earlier in the treatment algorithm. But the idea is adding that radiation, one, imaging it to identify which patients will benefit, and then actually adding the radiation for treatment has shown clinical success, and it's shown that that there is a path forward for patients and for the field to continue to treat and be a part of the treatment algorithm. So right now, again, this is mainly with small molecules and most commonly with prostate cancer and neuroendocrine tumor, because they have exquisite drugs that have been able to be leveraged for theranostics. Ideally, as more drugs are translated into the clinical field, the more will be translated into theranostics for minimally invasive biopsies, right? So looking systemically, seeing if different receptors are upregulated or downregulated in certain cancers. So one, I think that's going to help when we're treating patients even non-theranostically with these diseases, right? We're going to get a much better effect and a much more complete assessment of the person's their exact tumor biology, compared to now where we do a biopsy of one tumor in a patient that has 5 or 8, and we're assuming it's everything, right? But obviously each individual tumor mass may have a different biology. So I think one, using it to leverage for better treatment with conventional therapy, and then 2, using it as an option for like sort of beyond a last-ditch palliative therapy is I think where we're going, right? And I do think that we need to move it from systemic, where it's low doses that are given that are not curative, to a combination of curative local treatment of certain tumors, certain tumor masses, and combined with systemic. And I think there's an opportunity.
Sorry to interrupt you. So maybe, because, thank you very much. So this already, but to give a little bit more, go into that direction. So one question would be, so you mentioned that there have been some approaches already. So do you know which tumor entity they have shown an effect, and what is the amount of higher uptake if you have a local treatment versus a treatment that is systemically given? So do you have any idea on that?
Oh, so thank you for that question, esteemed professor. So in clinical practice, like it's been prostate cancer with various PSMA molecules, like PSMA 11, PSMA 617, and neuroendocrine with Lutathera, which is a dotatate derivative. So those are the ones that have gone the furthest in terms of clinical practice in theranostics. There are many other much smaller trials, even with antibodies, that have been done since the 90s, again, with varying degrees of success, but again, mostly as palliative therapies.
Maybe just let me to be more precise. So my question was, has there been a local therapy versus a systemic therapy? I know you know these ligands, but have these ligands already been used for local therapy? And what was the benefit there?
So with
can you briefly answer the question, please?
Yeah. So with the Ludia trial, that was when Lutathera was used intraarterially. There are other small trials, but this is actually it's a great trial. It's a prospective trial. So again, looking at tumors, they were able to specifically evaluate and separate the arterial infusion versus what would be the secondary systemic infusion on the opposite side of the liver. And
thank you very much. Looking at the time, I think I have to give back the word to the esteemed prorector. Thank you very much.
Thank you, Professor Motegi. The opposition will be continued by Professor Olde Daming. He's Professor of Surgery and Translational Research in Surgery at the Maastricht University Medical Center.
Thank you, Mr. Prorector. I want to start with congratulating you and your team with, for me, a new concept that I wasn't aware of, and would like to have some short discussion with you regarding Chapter 7. And my first question is regarding the choice of the model, because it's a young pig that is rapidly growing. Do you think that that can be a confounder for the tumors that you find?
So, thank you for the question, esteemed professor. So, again, this is a new model. However, it has been shown to have very similar vascular anatomy compared to human liver tumors. And it's never been tested in the kidney, but from what we saw, again, it also had a similar, it appeared similarly to a human tumor in the liver.
Would it be possible to induce these tumors in older pigs using the same Cree?
Yes, yeah. So
Would that be an option to compare it?
Yes.
Has it ever been done?
Yeah. There are a few, it doesn't have to be I picked smaller pigs just for the ease of doing the experiment. But yeah, but other larger, couple months older pigs have been attempted.
And then, so you, for the tumor inoculation, you had 24 sites.
Yes.
And then, so the success rate was 20 out of 24. How did you evaluate success? Was it by ultrasound?
Yes.
And why didn't you?
And ex vivo.
And ex vivo, both.
Yes.
Okay, good. So what could be the reason that it doesn't take in 4 of them?
Well, it's just it's hard to say exactly. So one, we inject a slurry of tumor, a slurry of the virus, and one it just may not have optimized exposure to the actual liver. So that may be, but our data is similar to the other data. But it's always about 80% when you do it percutaneously, and it's a lesser percentage, but possible when you do it intravascularly.
And then the success rate of ablation. Did you do the procedures yourself?
Yes.
So the success was the observer, the rater, blinded for the particle size?
No, it wasn't. No,
Or non-blinded?
It wasn't blinded. No.
And the other, it's going to be, it's just a short answer, please. The timing of ablation, it was immediate in your protocol.
Yes.
Now there will be discussions about going into the clinic, but do you think that we need to have more research on the timing of ablation, whether immediate would be preferable, or maybe after a week or 2 weeks? Can you speculate a little bit about what you think?
So I think because they're permanent particles, the ablation should remain for days to weeks. So I also think it depends on their equipment, right? If you have a hybrid angio and CT unit where you can do both procedures at the same time, it's easier for the patient if you just do it in one session. But clinically, in clinical patients who, in clinical facilities that don't have that, there has been a number of studies that look or could consider doing the embolization one day and then bringing them back the next day.
But it's very short, the timing of the ablation, huh?
Yeah, most of the time, yeah, they don't wait much longer. I would, again, it should be still embolized, but I think to ensure that it hasn't become, because you're thinking about you're going to get your
Neovascular
canalization from other vessels.
Would that be beneficial or counterproductive?
No, I think it would harm the
Success.
the effect of making a larger,
The ablation.
because you would get a diffusion of more heat away
Yep.
by the new particles that developed. So
Okay.
I think sooner is better.
Good. I'm very happy with your answers. We'll give them.
Thank you, Professor Olderdaming. The opposition will be continued by Professor Ritschak. She's present online, and she's an expert in radiology at the Memorial Sloan Kettering Cancer Center in New York. Professor Ritschak, your floor is yours. We cannot hear you. We cannot hear you, sorry. You're muted, I think.
Oh, yeah, now it's better. Thank you. Sorry. Sam, the presentation was excellent. Your work is outstanding. And I really want to congratulate you. I have been watching, mentoring you from the time you were a medical student. And you really have achieved. So congratulations to you and your family. And certainly a big thank you to Regina and the team that was mentoring you during your thesis. A few questions, Sam. One of them is, this is excellent work. It is innovative, it has courage, and it opens new venue and possibilities for better local treatment or combined local and systemic. So now, how do you foresee bridging the gap between this large animal model and early phase human trials? And I am especially, Sam, as you look at the vascular physiology immunologic response and regulatory hurdles for radiopharmaceuticals. So what are those challenges that you are foreseeing, but this is so good and should be translated?
Thank you for the question, esteemed professor. So mentioning the tumor, one negative aspect of the tumor is its growth rate, right? So these are rapidly growing tumors that develop in a week to 2 weeks. Most of the time, we haven't really looked at them long term and and what happens in them, beyond weeks and months. So having a rapidly growing tumor may have a different physiology compared to a tumor that's going to actually grow in humans. But on the other hand, having the size, the pigs being, having a similar, the tumors having a similar blood flow and makeup of the similar to human tumors in the liver and the kidney, I think that means that we can use this as preliminary data for when we apply for future grants, and I think that it's going to accurately reflect what we will see in humans, or at least be close. We didn't look at the immune effects, and I think that's something that we could look at in the future, because we do expect there to be some changes given that we're embolizing and treating. So I do think that, obviously for this we did not treat, but I do think that there's an opportunity there for us to see exactly how the local theranostic treatments in the pig or in humans are going to affect the immune response to the immune response, and then obviously use that to potentiate potential combination therapies with immunotherapy for improved treatments, right? Because I do think the radiation is going to, the presence of radiation is going to assist in when we actually give systemic immunotherapy.
Right. So, sorry, it was a little challenging question, but you did superbly. So, and I like biology. So what are the main biological and technical barriers which would prevent large molecule theranostics from achieving curative dose in solid tumors? And how might interventional delivery strategy like yours really overcome those compared to systemic approach like lutetium PSMA or CERT?
So obviously, then the really nice thing about the large molecules is that they're much easier to make and much easier to work with, right? So there's that potential to actually biopsy a tumor and tailor a new monoclonal antibody for that particular tumor. So that I see is the future there. But like I said, there are going to be negatives, right? So when you give it systemically, it's just that prolonged biodistribution has made it impossible to really get anywhere near curative doses into the tumor. Just because again, it takes hours to days for it to concentrate, and when you're using something like a beta emitter, it's just going to damage too many. It's going to damage too many organs and too many radiosensitive organs. So so I think it's been precluded, but I do think that local treatment is going to be the opportunity to open that up for its translation into humans.
Okay, just one more, just a follow-up questions. And do you think that your findings may impact on the design priority for future radiochemical agents, and also really influence across the radiology, nuclear medicine, and radiochemistry, such as design of the catheters?
Yeah, I think a lot of time and energy is currently put into improving the biodistribution and improving the excretion. And so I think that this will give the opportunity for drug design into more tumor-specific things and not have to worry about that excretion portion, right? So I think it'll make it easier to translate more drugs into clinical practice that have been precluded because of their radiopharmaceutical half-lives.
So thank you, Sam. You did superbly, and I apologize for putting you slightly out of your comfort zone, but that's where you really excelled. Thank you.
Thank you, Professor Richak, also for being present, because we realized that it's in the middle of the night in New York. Yeah. Thanks again. So the opposition will now be continued by Dr. De Wit van der Veen. She is an expert in nuclear medicine at the Netherlands Cancer Institute in Amsterdam. Please.
So thank you, Mr. Prorector. Dear Mr. Candidate, I would like to congratulate you and your entire team with this astonishing work. It's very innovative, as you mentioned before. And without a doubt, it has been a struggle to manufacture this work. But now I want to dive somewhat deeper into your presented results, and I want to focus on Chapter 3, where you use PVI to alter the flow of technetium MAA as a surrogate of your large molecule in the renal tumors, if I'm correct. And I have some concerns of the translation of MAA towards antibodies. In nuclear medicine, MAA, as you know, probably is mainly used for lung perfusion imaging, and that is because after IV injection, it gets mainly trapped within the lung and circulation system. So after the tracer gets trapped, then it takes quite a long time before it's released from the lungs and excreted to the kidneys. At least that's the case in humans. And if we now look at their results in Table 1, you see quite intense differences between the intraarterial and intravenous injections, and especially in the tumors. And are you positive that these results are solely caused by the PVA, or are there other factors?
So, thank you for the question, esteemed opponent. So MAA does have its intrinsic embolic properties, right? And like I said, in the lung mainly. So it is, it is difficult to definitely say that it was PVI, but I do think that when we do see the difference, when we do see the difference between the systemic IV versus the intraarterial, I think it kind of suggests that the PVI did have an effect. The other, we can't 100% say so, but I do think it definitely has an effect.
And if you would have done lung biopsies, would that have aided your?
Yes, I was going to say. So I wasn't going to do lung biopsies because they cause, you can get a pneumothorax, and then we wouldn't be able to finish the experiment. So that was one negative. I think obviously we would have seen a much higher uptake if we would have looked at the lung, particularly in the intravenous. It would have, I think it would have added, but it would have been a little just dangerous in like getting the you kind of have to. I kind of had one shot at it, so I did forego it, but I would have liked to get a lung, and then and to see, and I think that would have given us a lot of information.
And MAA is also used in Prasiert, as you probably well know, and it shows also there quite rapid degeneration of the technetium, the dislocation from the MAA molecule in the liver at least. And it redistributes quite quickly within an hour, so we have to have a very tight workflow to get the patient to the nuclear medicine department. And can you explain why this is not observed during the intraarterial infusion, in your pigs at least?
So I think that's maybe one of the positives about about PVI, that again we were able to block so much that even when it dissociates, it remains in the vessels without distributing into the systemic side. So I think if it remains attached to the MAA or if it dissociates, we have a similar outcome because of our embolization.
Yeah, and I'm going to challenge you a little bit more. If you have like this huge effect on pharmacokinetic behavior of your molecules, would you also expect that for the smaller molecules or even the antibodies? Do they also, this intervention affect the pharmacokinetic profiles of these molecules?
Wait, you're asking if the intervention affects?
Yeah.
Yeah. So I do think that, again, so I tried to pick molecules that were going to be similar to a small molecule, but obviously something that we could easily get and wouldn't have to to develop on our own, right? So these are clinically available. So I do think that the PBI is agnostic to the molecule. I do think that the process will work for small molecules or large molecules, and for specific tumor specific drugs like a PSMA or like an antibody.
And do you think that it's evenly effective in small molecules and in larger molecules? Because I get the impression that sometimes, especially the results on the bigger molecules, that the targeting of the molecule is also affected. And is that a problem then?
So I do think it's going to be better for larger molecule, right? I think that the small molecule one, it has great distribution to begin with, but I also think, again, when we talked about the dissociation, you're probably more likely, again, to get more of the small molecule into the systemic system, and we saw that just because, even though we're almost completely embolizing, right? There's still that opportunity, and you're going to have more of that opportunity with the small molecule.
Yeah.
With the larger molecule, I think that it will affect its distribution. It'll remain in the vascularity, and it'll have an opportunity, a longer chance to.
And if you have the molecule within the micro environment for a longer time, and at this point in time we are switching in the nuclear medicine towards more the alpha emitters, as you mentioned. Yep. Do you think that this approach will work better with the beta or with the alpha emitters?
Definitely with the alpha emitters, right? So I think that when you're looking at things like Y90, right, where it just stays inside the vessel, you do need a little more distance, especially when you're treating larger tumors. So you need to have the distribution throughout, and then so it can, so it can get more of that cross hatching. I think that because these molecules are going to be stopped, they're going to be more likely to exit and go into the matrix and be associated with the tumor. Having that alpha is going to lead to better treatments and less of a chance to also affect other organs. So. Yeah.
And my last question then, you mentioned the Lucia study a couple of times, and it's a study where you have the liver, main liver disease, but also at several sites throughout the body there were also lesions. And in that study, the setup was to treat one lobe, then have a large first pass effect, and all the other lesions were treated with a second pass effect. But if I look at your results, and especially with the large molecules, almost all molecules are sort of trapped within the tumor, which in fact is great. But if you have systemic disease, are you afraid that using this technique you have under-treatment of other sites?
So I think that this is that there's going to need to be a combination of therapy, right? So larger tumors, kind of debulk those, and then with systemic. I don't think that the combination, with PBI, it's going to, obviously we want to limit the amount that's going to be systemic, right? So I think that there'll have to be some combined therapy where we maybe treat the local with an alpha, and then a few weeks later we treat, we do some systemic treatments for the remainder. And I do think that that combination is going to lead to the best outcomes for the patients.
So that means new dose escalation studies?
Yes.
Okay, thank you very much. Dear Mr. Prorector, I would give my turn to you.
Thank you, Dr. De Wit van der Veen. Then the opposition will be continued by Dr. Klompenhauer. She's an expert in interventional radiology, also at the institute, at the Radiology Institute at the Netherlands Cancer Institute in Amsterdam. Sorry. Go ahead, please.
Thank you, Pro-Rector. And first of all, I also want to congratulate you, the candidate, but also your entire promotion team, Dr. Bates-Tan and Dr. Gomez, and congratulate your family with this really impressive manuscript. I think that it's really valuable to generate this in vivo data. And I think even the manufacturer is really jealous of your data, of the microwave ablation system. And it can be of great potential for the clinical relevant. And you also, you particularly drew my attention also on the concept of the pseudovascular isolation, because I was not really familiar with this term prior to reading your manuscript. And I think you're actually the first one describing this technique, is that true?
Yes, yeah.
Okay, nice, nice. And I was a little bit, because you use really small microspheres, the same as we use for the tumor embolization. And if I would consider performing this technique in clinical practice, what guidance can you provide me on how to determine the appropriate endpoint? So I want to stop the efferent flow, but I don't want to embolize the tumor.
Yeah.
How can I do that?
Yeah. So, thank you for the question, esteemed opponent. So I think, obviously we're taught as interventional radiologists, we want to have complete stasis, right? And so that's usually 5-beat stasis, at least, right? So I do think that there has to be a middle ground for this PVI, because we still want to have that forward flow. We don't want to have embolization of all the vessels. We want it to be able to stay in those tumor vessels and then exit the endothelium. So I think ideally we would be using smaller particles than even 40, right? I think the capillaries are about 10, so like 10 to 20, I think would be more ideal. And then I do think that you want to still have that forward flow. So you want to have stasis, but you want to also have the ability to, when you inject, for the theranostic agent to go forward. And then I think in addition, the use of pressure generating catheters can help, right? Because then you'll increase the osmotic pressure even more and you'll push more out. So I do think that there are a lot of techniques for us to, that we need to look at to make this a little better.
Yes, thank you. And I was wondering, do you think this proof of this PVI proof is already proven enough, or do you need more proof of concept? And if so, how would you do it?
So I think that this data is good enough for for us to translate. I think that that's the positive part about Theranostics, that we don't have we don't have to start off with the treatment. Right, so similar to a radioembolization with Y90, we can have that mapping procedure initially with the low energy imaging agent, right? So then if we're not getting the same results, or we're not able to concentrate the way we want, one, we can work with the dosimetry, so we can have that individual dosimetry, and then two, we can say, hey, this isn't working, we're having too much systemic, or we're not having not enough systemic, we're not having enough in the tumor. So I think that because we have that opportunity to have that safe sort of backup, I think that with this data could be used to get grants and move it into the clinics.
Yes, thank you. And I was wondering, because you probably also have a hybrid room in the CT angio at the place you work, could that be of help to determine your endpoint of the PVI? So, for example, the CT with intraarterial contrast, or even a perfusion CT? Exactly,
yeah. So I think that's something we can do. We can do the PVI, then do a perfusion study, and then we can have a much better sense of how much we're getting into the tumor and where. So I think that there are a lot of opportunities with advanced in imaging, and the combination of CT and angio.
Yes, thank you. That's really, I think that would be a really nice solution. And a final, really short question on this topic, and you already mentioned it a bit in your talk. Nowadays, we have also biodegradable microspheres. Would that be maybe beneficial for PVI?
So I think that would be ideal for PVI, right? So I think you get, like you said, you get that initial hypoxic environment, but then you also allow the tumor to to get continued flow after. So I think that ideally, we don't need to have the full, because again, we're also not going for complete stasis, right? So it's not really treating, but I think opening up those vessels and after it's treated, will work in a number of different areas. One, it may also cause an ascopic effect, right? So you get those cells, you get that immune response, so versus if we had complete embolization, you wouldn't get that. I do think that again, it's going to be out of the vessel, so even if the particles are gone in 24, 48 hours, we shouldn't see a lot of distribution. And then I just think again, it's just more physiologic to allow the blood flow back into the tumor after PPI.
Yeah, I totally agree. And I think it's also an opportunity to have separate multiple intraarterial treatments afterwards. So
Yeah.
same procedure or maybe a radioembolization or a TACE procedure afterwards. Yeah, thank you very much. So I'm really satisfied with my answers, and I would like to return the floor to the prorector.
Okay, thank you, Dr. Klompenauer. The opposition will be continued and finalized by Dr. van der Leij. He's interventional radiologist at the Maastricht University Medical Center. Please.
Thank you, Mr. Prorector, and Mr. Candidate. Of course, also my congratulations to you and your team for the excellent work. Especially, I was impressed by the PEG model you used, the easiness of the induction of tumors in the liver and kidney, which is actually quite straightforward to use. So I'll think of that model for myself for future experiments as well. Regarding your papers, I would like to discuss with you Chapter 7 on the liver ablation. As interventional radiology, I do a lot of liver ablation. So actually, and you conclude that with added embolization of arterial supply, this, especially with smaller particles, zones will increase. That's what I'm right about?
Yes.
Okay, so which is useful actually as we are treating more and more larger tumors, not to replace surgery, but to help surgery. Because we're all working together, of course, and we are doing more and more intraarterial injection of contrast during ablation, so which makes it easier to add an embolization strategy as well. And you say, well, especially smarter particles create a larger ablation zone. Am I right? And maybe you could explain why you think why is that?
So thank you for your question, esteemed opponent. So we did see with the smaller particle a larger ablation zone versus when you're doing 900 to 1200, it's probably a more central ablation. So I think again what we're dealing with is that passive heat that's diffusing out, and so I think that if you're packing the tumor and you get that complete embolization, then it doesn't allow that flow on the outside from these small vessels to go in again, to diffuse as much heat. So I do think that's probably it, right? Versus if you do central, you still have that peripheral. Again, you may not have larger, a large vessel, but you still have these probably small, like capillary-sized vessels that can remove the heat. So that was my thinking behind it.
Okay, but then again, then we take the smallest molecule there is, which you use actually, which is lapiodol. And in that case, the ablation zones are smaller. So what you actually would expect is, well, it's the smallest particle. They would be even bigger, but they were smaller. How do you explain that?
So I think that that lapiodol just isn't completely embolic.
With TACE, for example, we use lapiodol as well, and we see that it stays embolic.
But I think with TACE, so again, so for me, I'm more, I grew up on the bland embolization, and I think it's more of the bland embolization at the end that's causing. So yeah, the lapiodol is is the smallest. It's going to get into the capillaries, but I think from this, again, I definitely thought it was going to be more embolic than it was, but I think that it ends up being, the emulsion just ends up being more of a way to release the chemotherapy slowly and less of an actual embolic, unless you're adding the particles. So that's kind of what I got away from, got out of my study.
Okay.
But yeah.
Okay, but I have another theory then, and I would ask you to challenge my theory then, because when you add something to the ablation zone, for example, a pyridol, it's an insulator. So it's an insulator because it's a fatty substance. Yeah. And if you add the small particles within the ablation zone, so the larger particles stay outside of the ablation zone, but the small particles will probably be more in the ablation zone. Don't you think you also change the thermal conductivity of the tumor? You just embolized actually by adding smaller particles or lapidol, and does this give us the opportunity to really tailor your ablation zone to the tumor, to the tumor in future? So maybe we add some lapidol, a mixture of lapidol and small particles, and a mixture of lapidol and larger particles, to maybe change the perfect ablation zone, try to get the perfect ablation zone for the tumor.
Yeah.
But maybe you have ideas on that.
No, I think you're right. I think from that's what I got out of this. I think that in the end, I think the combination of the particles with the lapidol would be the best agent to use. I do think that that's true. We didn't use that here, but I just think that the lapidol alone, the emulsion alone, just isn't going to give you enough embolization, or it may be a shorter term embolic, like more of a temporary embolic, and it opened up soon, sooner than I thought it would. Again, I thought it was going to stay longer. But I do think that combination and adding the lapidol, one for the staining, and then two for the combined embolic, I think would give us the best opportunity to one, look at the ablation zone, identify our tumor, and then increase the ablation zone size.
Okay. Thank you. Then I think we are on the same page. And what I also see a lot when doing ablation is there is quite heterogeneity between, for example, if you ablate for 4 minutes, 65 watts, you use the new wave device. I guess. Between patient A and patient B, there's a difference in ablation zone. I think both my colleagues can also agree to that. Yeah. Did you also look at the variation of the ablation zones after embolization, and is the ablation zone more stable after embolization than without embolization?
So I'm looking at the standard deviation. I do think that we were getting more uniform ablation zones with embolization compared. And then, like, even if you look at compared to what we actually did with our control versus what the new wave advertised was different. So I do think that I think that that's one of the issues with using microwave, right? That we have these variable ablation zones, and we are having a difficult time actually, again, you kind of guesstimate based on what you think, but every person is going to be different. So I do think that adding the embolization is going to be a little more standardized, and provide a more, like I said, a homogeneous treatment zone from patient to patient, given differences in like liver texture, cirrhosis, non-cirrhotic. So I do think that it just adds that extra. It kind of levels the playing field for, I think, for different tumors and different people.
Okay, thank you. I think I have some more time, or okay. Well, it's actually quite similar because you already mentioned the liver is it's a dual blood supply. So if you embolize the arterial part, then there's always portal perfusion as well, and there are more collaterals in the liver, but in the kidney they are all endothelius. So how does it work that you also get a larger ablation? That puzzled me a bit. A larger ablation zone with smaller particles in the kidney, while there's no real collateral perfusion, or not in my knowledge actually, but maybe you comment on that, with smaller particles, larger ablation zones than with larger particles. That would be very unlogical to me.
So I still think there's still collateral flow, right? Like I think if you
You may briefly answer the question.
So I do think that, again, it's about having, you still will have peripheral, right? If you do that central, then, now here. If you, but I also kind of broke it up. Like, I didn't just do like the particles in the main. So you still maybe have half the tumor. You still have half, like let's say the upper part of the artery feeding. And so you have the vessels there versus when I go further in, because the particles went deeper, then again, you're going to have more of that actual tissue that has been embolized versus when I went central, less of it was embolized. So I do think that there's probably going to be some diffusion from the upper portion or the lower portion, right on that edge. And these also are small tumors. So I mean, small kidneys. So so I think that that's why I picked such small ablation zones, ablation times. So I do think that there probably was some cross. Flow.
Thank you.
Thank you.
Thank you, Dr. van der Leij. Mr. Samuel Rice Jr., the time appointed for defending your thesis has now passed. The degree committee will withdraw to discuss the quality of your thesis and the quality of your defense, and I request that you and your company await the result of our deliberations in this and our return in this room.
Okay.
Mr. Samuel Rice, Jr. The degree committee here present has assessed the quality of your thesis and the quality of your defense. In view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Beetstaan is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to take the floor.
Please all rise.
Okay. Sam, I first would like to ask you, okay, I need glasses already. Do you promise to work in accordance with the principles of scientific integrity at all times?
Yes.
To be careful and honest, transparent, independent, and responsible.
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Samuel Louis Rice, Jr., the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the University of Maastricht. Here it is, Sam.
Please be seated.
Dear Doctor, dear Sam, you made it. Congratulations also on behalf of your co-promoter Fernando and your colleagues who are probably following this proud moment both here and online. You have defended your thesis exceptionally well, and to be honest, I never expected anything else. Your early academic journey began in 2010 during your research fellowship at Memorial Sloan Kettering Cancer Center in New York. You were profoundly shaped by the leadership within the Department of Radiology under the legendary chairmanship of Professor Hedy Richak, who is here joining us today. Hedy, one grateful word to you. I'm deeply honored that you are with us as Sam's opponent, because I know that the hour is very challenging. So thank you for that. And also thanks to Professor Jason Lewis, Deputy Director of the Sloan Kettering Institute, who introduced you to the molecular research. You reached out to me in 2017 to ask whether there might be a position for you in NKI as an interventional radiologist and researcher. I remember our conversations in New York City and thinking this is someone with enormous potential as a clinician, as an innovator, and as a future leader in interventional oncology. Your arrival in Amsterdam and in my team in 2018 could not have been better timed. We were just building our interventional oncology program, and I was delighted to welcome you in my team. Your Dutch interventional radiology colleagues, Lisa, today as your opponent, and Tarek, proudly standing beside you as your paranymph, remember those days, I think, very well. You were a kind and enthusiastic young doctor, eager to contribute, but also visibly navigating the challenges of a new language and a new culture. Yet you stayed positive, always smiling and always trying your best Dutch on patience. And because back then AI translation tools were not quite what they are today, you relied on a translation app that, shall we say, had a rather creative imagination. Sometimes it turned your careful clinical explanations into some poetic or mysterious sentences that no Dutch person had ever heard before. But the patients adored your effort, and we admire your bravery for letting Google Translate speak on your behalf. I don't think someone has ever told you that Dutch is one of the most difficult languages in the world. Then there was your phase of intermittent fasting, I was told by your colleagues. Quite a cultural contrast in a country where people eat every 90 minutes. So because you didn't eat the entire day, you didn't join the team for lunch at the hospital. Your colleagues even started a long-term bet about who would be the slimmest after 10 years, the intermittently fasting American or the Dutch interventional radiologist who survive on syrup waffles and coffee. I am still not sure who. Your American training showed in everything you did. Precise, structured, thorough. The kind of reporting where not a single comma, vessel, or lesion could possibly be missing. And you kept a bit of your American rhythm. Those long New York resident hours, you sometimes still drifted into sleep at work. Not dramatically, no, not at all. Just quietly, elegantly, like someone who had been awake for 36 hours a few too many times during your residency. So we understood, Sam. But no matter how tough things became, and they did become very tough for you, you were never unkind, never discouraged. You remained positive, warm, and gracious. That is simply who you are, Samuel. So when you eventually came into my office to tell me that you had decided to return to your home country, I understood that completely. But I also felt a little bit sad to let you go. Yet, before you left, you expressed your ambition to complete a thesis under my supervision. And I must confess, I thought it might remain just a distant wish given your full-time clinical duties. But those who know Sam understand. If Sam says he will do something, he will do it. He will do it politely, with a smile, with 3 backup plans, but he will do it. And so in the evenings and weekends, outside your busy full-time clinical work at University of Texas Southwestern Medical Center, you independently continued to design and carried out your ideas, which are innovative studies, with Fernando and me guiding you from afar. You're one of those rare PhD students every supervisor hopes for. Your studies were not only innovative, they were impeccably executed, and your results were clearly analyzed and beautifully written. Your papers were essentially submission ready the moment they landed on my desk. Your intelligence, creativity, ambition, and dedication have led to the work that has now resulted in this beautiful, excellent thesis with genuine potential to be groundbreaking for the field of interventional oncology. Samuel, I am incredibly proud of you. And I'm grateful that you once asked me for a position in the Netherlands in NKI. It showed courage, resilience, and determination to move alone to a different city, a different culture, a different language, and to find your place. That is no small thing. Your contribution to interventional oncology in my team and center and to your team colleagues has been lasting and meaningful. You have expressed the ambition for an academic career, and let me tell you, today is only the beginning. You have achieved something remarkable, and I look forward to everything your future will hold. And you know, I've already told you, I will always be there to support you. Fernando, Lisa, Tariq, and probably some Dutch old colleagues in the NKI who have witnessed your defense online today are all extremely proud of you as their colleague, proud of your warm personality, and proud of your achievements. My congratulations and thanks go to Fernando, your co-supervisor, with Sam in the US, Fernando in Spain, and me in the Netherlands. This work turned into a real multinational, multi-continental collaboration. My heartfelt congratulations also go to your loved ones, your partner Julia, your dear friends Mariel and Amanda, who have come all the way from New York City, but also from Texas, to celebrate this milestone today. And Samuel, although your father, Mr. Rice, and your sister Tammy are no longer with us, I know with certainty that they are present in spirit today, proud and standing beside you in this moment. I also got emotional. Finally, a word for your mom, Mrs. Rice. My sincere congratulations. It means the world to Sam that you undertook the long journey to be here today and share this important moment with him. I can only imagine how special it must be to have a son like Samuel. I have spoken.
Highly esteemed Dr. Rice Jr., it's a great honor for me to congratulate you on behalf of the University of Maastricht and the Board of Deans with the achievement, the degree that you have just acquired. I, of course, also would like to congratulate your supervisory team, Professor Bates-Dunn and Dr. Gomez. And special congratulations, of course, go to your family, your mother. I think you should be really proud of him. And what I understand from the acknowledgements in the thesis, your son is very proud of you. Also your partner, of course, congratulations, and the other family that is present here. Also, I would like to congratulate all that have collaborated to your studies. The research is not done alone. It's multi-research collaborations, and also those need congratulations, I think. Maybe I can explain a little bit what we deliberated on your thesis and on your defense. It has been said already. It's a very nice, complete study, work, well written, your thesis. Your studies are extremely innovative, it's clear, and I also heard the word courageous. because it was very courageous to embark on a study that is that new, that it opens new clinical therapies for the future. And I think you have an obligation now. You have proven to be a very good scientist, and you have an obligation now to continue with your research next to your clinical work. And I'd like to wish you then also lots of success in your further scientific and clinical career and your studies applying these advanced molecular techniques in your for the benefit in your work for the benefit of the cancer patient. Having said this, I have a few announcements to make. We will, after I finish the ceremony, we will briefly stay in this room. The two opponents online will appear on the screen and we'll make some pictures, and I would like also to invite the family to join us here. And after that, we will go to the staircase and have some additional images. And also will give the opponents online a chance to congratulate you. Having said so, I hereby end this academic ceremony.
Want to open